Just want to welcome everyone again joining our Mental Health Parity Series #1 webinar sponsored by the Kansas Mental Health Coalition. The Kansas Mental Health Coalition is a statewide advocacy coalition. We are a roundtable organization, and our members come from providers, family and consumers. We have community mental health centers, hospitals, pharmacy organizations, insurers, really anyone in the state of Kansas who is interested in pursuing our mission of improving the lives of Kansans with mental illness. Many years ago, when I started working for the Kansas Mental Health Coalition, we were pursuing a state mental health parity law. And my name is Amy Campbell. I am the lobbyist and coordinator for the Kansas Mental Health Coalition. In a few minutes, I will go ahead and introduce our panelists, but I see we still have a few folks joining us. Okay, it is time to get started. First, I would like to introduce the president of the Kansas Mental Health Coalition is Mary Jones. We also have with us Audrey Dunkel, who is the chair of the Parity Committee that is sponsored by the Kansas Mental Health Coalition. And today we have Sandra Berg from United Healthcare, Inc. She is our special guest presenting from the insurance industry perspective. If you have questions throughout the webinar, please be aware that this event is being recorded. You are welcome to put comments in the chat. If you have questions for any of our panelists, please go ahead and put them in the Q&A. We will go through our presentation first and then have Q&A at the end. Okay. I'm trying to get my full screen up here. Here we go. To begin with, the Kansas Mental Health Coalition's Parity Committee has wanted to begin a conversation about mental health parity policy rules, kind of how it works. We would like to engage our partners in mental health services, including families, including consumers, including the regulators for insurance and the insurance industry itself, as well as the policymakers, our state legislators who make the rules for how Kansas insurance policies are sold and regulated in the state of Kansas. This is our first webinar for this series. We are open to recommendations from any of you about what you would like to see in the future. The next 2 webinars that have been planned will be occurring on basically a monthly basis. The Mental Health Parity and Addiction Equity Act of 2008 requires health insurance carriers to achieve coverage parity between mental health, substance use disorders, and medical surgical benefits, especially in regard to financial requirements and treatment limitations. So parity in the context of the Federal Parity Act refers to equal coverage. What does that mean? What is equal coverage? It basically means, if you look at the federal definitions, coverage provided by health insurance that is no more restrictive than coverage that is provided for other physical health benefits. The parity laws do not require unlimited access to mental health and substance use treatment. Parity laws do require comparable coverage or no more restrictive than access to mental health and addiction treatment as that which is provided for treatment of other health conditions. What health policies are subject to the federal parity law? The Parity Act originally applied to group health plans and group health insurance coverage. It was amended in the Affordable Care Act to also apply to individual health insurance coverage. Now, what's very interesting about the Parity Act and our interest as a committee is we want families and consumers to understand what it is that they are entitled to. But as we have learned, the issue that comes up is that there are different entities that regulate different types of insurance policies. So it can become very complicated. The United States Department of Health and Human Services has jurisdiction over public sector group health plans. This would be things like Medicaid. This is the HHS, while the Department of Labor and the Treasury have jurisdiction over private group health plans. In Kansas, our own insurance department regulates and approves health plans that are issued in Kansas, as long as they are non-ERISA. In other words, they are not self-funded corporate health insurance plans. Many employer-sponsored plans that you would find under a large employer come under federal regulation and not the state. And in the meantime, the Kansas Department of Health and Environment manages the contracts that the state holds with the 3 managed care organizations who implement our KenCare program. So those health plans are subject to both the federal HHS rules and then also the contracts with KMHC. Basically, what mental health parity is that if a group health plan or a health insurance plan includes both medical surgical benefits and mental health substance use treatment benefits, those financial requirements, deductibles, co-payments, and treatment limitations, that includes things like the number of visits or the number of days of treatment. Those that apply to the mental health benefits have to be no more restrictive than those that apply to substantially all medical surgical benefits. That sounds very simple, but obviously things can get more complicated when the rubber meets the road and in practical application. So what happens if people feel like their insurance coverage is not complying with the federal or the state Parity Act? Basically, the issue is that's what our committee is looking into. And we think it's very important that families have an understanding of what they are entitled to and also know where to go to have their problems resolved. That's basically a background relating to mental health parity. I'd also like to talk for a minute about kind of the current events. Our Parity Committee became active several years ago as we were seeing new activity occurring at the national level and a new awareness and emphasis relating to mental health parity, the Federal Parity Act, and reviews and studies relating to how well it was going on a nationwide basis. There are several entities who have really gotten involved in this new emphasis relating to mental health parity. At the national level, the National Association of Insurance Commissioners has formed a committee that studies the role of state regulators to better implement the state laws and to coordinate with federal regulators about what the definitions and regulations need to be relating to insurers and providers to assure that policyholders are getting access to mental health care. Additionally, this last January, the Department of Labor, Health and Human Services and the Treasury issued the 2022 report to Congress on the Mental Health Parity Act relating to how it was going. Basically, that report came out and said there are a lot of obstacles that are occurring across the country and some barriers in the implementation of parity nationwide. It makes some recommendations on what they would like to do at the federal level to improve these conditions. Most of that is related to how federal entities and state entities can boost enforcement and understanding within the industry about what the obligations are. Additionally, a number of states have passed model legislation that boosts enforcement of parity laws, further defines parity rules at the state level. This is something that the Parity Committee will be looking at more closely in a future webinar. One thing that you might have read about is the WIT versus UBH federal court decision that found that the insurer's mental health rules were flawed and that they were not consistent with generally accepted standards of care. That trial court required that over 60,000 mental health cases be sent back for re-review using the generally accepted standards of care developed by independent, expert, and professional organizations. Subsequently, that case was appealed, and the Ninth Circuit Court of Appeals reviewed the case and issued a reversal, saying that the lower court's case was not correct. That we're now looking at entities who are going to appeal that case and asking for a rehearing. So all of that is still pending. Our committee has been looking at the general standards of practice that were put forth in that court decision as a solid basis for reviewing whether or not insurance plans are properly implementing parity. One entity that you might find useful is the Kennedy Forum. It's a national nonprofit organization that partners with the Parity Implementation Coalition, the Treatment Research Institute, the National Business Group on Health, and others to develop consensus on parity issues and policies that will ensure continued progress. I hope this gives you a good background on what we are looking at when we're trying to study and implement improvements for mental health parity. We're very pleased that today we have Sandra Berg from United Behavioral Health. She is also a member of the Kansas Mental Health Coalition. We've worked with Sandra for a lot of years in other roles outside of United Behavioral Health. So thank you so much for being here today to talk to us. She's going to give us a little bit of the perspective of United as they are looking at changes and developments across the country.
Thank you, Amy, and thank you for inviting me to come and talk today. And I appreciate you bringing up the case from UBH that took place a couple of years ago around our commercial product line. And I'm going to share my screen real quick. Oh, no, guess I can't. Never mind. I'll just go through some numbers real quick, just to kind of lay the land for you guys of what Optum and United Healthcare cover. So United Health Group, which is our parent company, we have 350,000 employees, and we have, in those 350,000 employees, we have 137,000 clinicians. Those are people licensed either as nurses, as pharmacy professionals, behavioral health professionals. So even in our own organization, we have people with mental health backgrounds that are working together to make sure that people are getting the services that they need, not just from an insurance perspective, but also from a service delivery perspective. And even globally, we serve people across the world. So 148 million unique individuals are served globally through our different product lines. And when I talk about product lines, I'm talking about commercial, Medicare, Medicaid, employer-sponsored plans, commercial plans. Just within the United States, we cover 50 million people under Medicaid alone. In Kansas, we cover 174,000 Medicaid folks. So that kind of gives you an idea of the scope of United Healthcare within insurance, but also what we cover and the services we provide within behavioral health. So when you talked about the UBH settlement and the ongoing appeals, one thing that came out of that is we went back and looked at the criteria, the clinical criteria that we were using to make determinations. And from that, we made the decision to stop using our own developed clinical criteria and went to a nationally used model. So some of you may have remember when we went from our own clinical criteria and went to the locus, CalLocus, and the XE clinical guidelines for making determinations. So when you're looking at parity and what your insurance providers are using, look at their clinical guidelines. That's going to be important to do when you're making a comparison of whether you're getting equal treatment. Are they using a nationally approved clinical guideline? And ours are all listed on our websites, and I'll put it in the chat, the links to our clinical guidelines so that you guys can have those. But that was one thing that came out of that I think is really critical for folks to know is we are always looking at what improvements can we make. We have a whole team of people that all they do is mental health parity. I have an attorney within our organization that reaches out to me every month. Is there anything new that she needs to know about that's going on with mental health parity? And is there anything that I need to make her aware of? So it is something that's on the forefront with the magnitude of what goes on within our organization. Yes, we're going to have missteps. It's going to happen. But I think our organization works hard to make sure that we are staying abreast and staying on top of keeping mental health parity first and foremost, especially given now that we are expanding into the provider space and nationally to make sure that we are getting services out there.
Do you want to talk for a minute about what that looks like?
As far as providers? Yeah, so we don't have it so much in Kansas as we do across other states, but Optum Care has really been expanding into providing behavioral health services. A lot of it's telehealth, but providing behavioral health services and integrated services within different states and different providers. We've purchased some provider groups and we wanted to be able to help people get into services where there were gaps. And so we've see if I can find the numbers, recently purchased a group that covers the eastern part of the country, and really are focusing on quality of services and getting people what they need. So I think the company is diversifying from insurance and going into the provider space and providing services as well. So it's to our best interest to make sure that we're staying up on parity as well, because it impacts our business too.
Absolutely. I wondered if you could talk for a minute how parity considerations for a company who is participating in the Medicaid program might look a little bit different than an insurer who is selling commercial plans.
Yeah, the differences are going to be about your regulations. And like you said, Amy, before, the regulations are going to be much different. The state obviously regulates more for the Medicaid space than it does for the commercial. Our regulations around our contracts are pretty stringent, and they come from CMS, but they filter through the state contracts. So when I have to go through a state audit, it takes weeks to prepare and get ready and go through that. We're in the middle of it right now. And it's pretty thorough. So it covers a whole spectrum of access to care and, how we contract with our providers and how we pay our providers. And, there's a whole spectrum of services and whether the benefits are being paid out. And, I have not experienced that from the commercial side since I haven't worked on it, but my experience from talking to colleagues on the commercial side of it is they don't have that regulatory oversight that we do in the Medicaid space. So when you're working in the Medicaid or even in the Medicare, you have a lot more of a regulatory oversight than you do in the commercial space.
I can see that would be true. I will just share with the group that the Mental Health Coalition Parity Committee has been meeting annually, if not a little more often, with the Kansas Insurance Commissioner, Vicki Schmidt, and her legal staff as they educate us and share with us what they are learning from their national participation in these committees, and then what they are implementing at the state level to try to have a more active regulatory presence and view and focus on whether or not policies still in Kansas are keeping track of whether or not they are meeting federal and state parity laws. It's been very interesting, and I believe that focus will probably gradually increase within the state. And we will, at a future webinar next month, have a guest with us representing Blue Cross Blue Shield of Kansas, because I know that their company has internally been increasing their own focus on how their procedures align with federal parity requirements. I'd like to now move to the Q&A if people have questions. So let's see what we've got. That is not a question for it. Does anyone have any questions for our panelists?
Amy, I did put 2 links in the chat. One of them is on our mental health parity information that we have on our website that people can go to see what we put out there. And then the other one is the guidelines around our clinical evaluation for services. Oh, and there's also some free training out there on the second link if folks are interested in training. And sometimes we do have training on parity out there as well.
Help me understand what the training, it's for your members it's for clinicians?
It's free for anyone.
And it's just basic guidelines about what it is?
There's trainings out there for anybody that wants to go out there and sign up. You can go in and take any kind of training that you're interested in. I mean, there's training on diabetes, there's training on different mental health disease states. There's all kinds of training. It's called Optum Education, and it's a free service that we provide for anyone that wants to go out there and use it.
So we do have a question from Dana Scheffelman. How does mental health parity address deductibles? Can insurance have two separate deductibles for physical and mental health? And can they be different amounts? So you don't have deductibles within the Medicaid program. But what I can tell you is that under the Affordable Care Act actually further defined the issue for deductibles, because it had become a common practice for commercial plans to charge a higher deductible for behavioral health services. And the issue under the Affordable Care Act was to more strictly define that so that a policy who has different deductibles for primary care versus specialists, there is that option. But for mental health care, there has to then also be general care deductibles that are no more restrictive than or no more costly than the comparable services under the physical health side. So you should not be seeing a dramatic difference between the deductible costs for the different types of services. Yes, Shelley. Shelley Duncan points out we mean copays, not deductibles. That is correct. I'm not very good with my terminology sometimes. So I would also point out that we have in the state of Kansas had various pieces of legislation introduced, and those bills have, some of them get hearings, some of them do not. And my eloquence with terminology is directly comparable to how often we're talking about it under the State House dome. Chad Childs asks, do you anticipate any significant impact on parity with the expansion of Ccbhcs in Kansas? So the Ccbhcs are the Certified Community Behavioral Health Centers licenses that were recently approved by the Kansas legislature. We have our first round of mental health centers have been certified as Ccbhcs just now, like since the beginning of May. And so they will be eligible to receive a different kind of payment under the Medicaid program for the services that they provide. The area in which I would view this as a parity issue, and Sandra, you can help me with this, is in the area of having services approved and whether or not the Medicaid member is deemed eligible for those services, and then whether or not the Medicaid program will apply any kinds of limitations to that access of those services.
Yeah, currently there are no limitations that I can think of. The only thing, there are members who have a spend down that have to be spent before they are eligible, but that would apply to any Medicaid service, not just Ccbhcs. So if you're over the federal limit, you have to spend down to get Medicaid to pay for your services. It gets complicated, but those are the only folks that I could think of. Other than that, there are no prior authorizations. There's no limitations to the services within the Ccbhcs.
So it might be that there is a greater access to services in the Ccbhc model parity won't be an issue as it relates to payment because only Ccbhcs are eligible for those types of payments. So that's
Correct.
not something that goes across systems. Can you talk a little bit more about how spend down applies? Because I thought that Medicaid spend down was mostly for folks who are eligible for certain types of waiver services.
I'm not sure it just applies to waiver because there are folks that are
Mary
non-waiver.
looks like she really knows the answer to this question.
Mary, bail me out here. I'm getting in over my head.
Yeah, well, the spend down process is income based, and so it applies regardless of waiver service or non-waiver service. The waiver services have sort of this contribution that each member has to make. The spend down is based on income, and so think of it as a deductible that happens every 6 months that members have to meet.
Okay.
Yeah. And once they meet their spend down, then Medicaid will kick in 100%, but they have to meet that spend down first. And so that's where that would be the only limitation that I can think of within the Ccbhc.
So in essence, when you refer to spend down under Medicaid, it's actually a copay for what they can receive because they have to pay more of the cost of their service than folks who have who come in under the income boundary. Is that correct?
Yes.
Does anybody else have questions for any of the panelists? Okay, sorry, I'm having a little trouble with my scrolling here. Folks are putting things in the chat instead of the Q&A, so it's hard for me to know if these are actually questions for the panelists. There's a question here. So I'm having to scroll if folks can just be patient with me. Can you provide an update on the market conduct exam being conducted by the Kansas Insurance Department? So, and this kind of relates to what Sandra said about the audits that MCOs do under their regulation. The Kansas Insurance Department is conducting a market conduct exam related to parity on a large insurer in Kansas. It has not been publicly revealed who that is, although I have had conversations with folks who are being pretty open about it. And then that market conduct exam is supposed to wrap up sometime this summer. The exam, the agency will then review the results. They will provide their report. The insurance company will then meet with if they are deemed to be in violation in any way during their meeting with the insurance department, there will be an opportunity to correct that situation and a period of time for them to do that. And none of this information will be available to the public until all of these things have happened. So we don't expect to be seeing a report on this until maybe late fall, perhaps before the next legislative session. But I do think it's going to be a very interesting report that can kind of update us on the status of how things are going in the state of Kansas. As I mentioned before, the insurance department is increasing their focus on parity compliance. And so this will be sort of a first round examination of how that's going. There's a note here from Jennifer Prohaska saying it's becoming increasingly difficult for clinicians to recoup insurance payments from insurance companies, sometimes 5 hours on the phone on hold just to clarify one claim. Leads to, it takes a lot of valuable private practice clinician time. leads to private practice clinicians dropping insurance, and that's a problem. And again, that is one of the things that was discovered, I think, if you look at nationally based parity reviews, this is something that they are commenting on, is that more and more providers are just saying that it's just not worth it to have to try to jump through all of the hoops that insurance is requiring us to jump through. I would just also add, though, that many insurers are doing kind of an internal review of their processes to decide whether or not it's worth it, because they also have a person on their end who's on the phone for all of that time going through these processes and doing all of these procedures. So that creates, so on the other side, you also have an interest in reviewing whether or not this is worth their time to do all of these reviews. Is it assuring better care? Is it saving significant dollars? At the end of the day, what is being gained? I know that United had that experience as well.
Yeah, to add to what you're saying, we have access standards that we have to meet, and folks have to get in to see folks within a certain amount of time. And if we cannot get people in for the reasons that Jennifer is identifying, that their clinicians are on a phone waiting to answer a question about a claim, that falls back on us too. So, we want to know when these types of things are happening here at United so that we can address those and get our providers back into providing services, not doing administrative work. So anything that we can do to help reduce that administrative burden, we're all for it. Yeah, we're going to have issues and we're going to have glitches in our system, but, we need to know about them so that we can get them back into providing services. So I appreciate Dr. Prochaska, bringing that up so that we can make sure that we're addressing them.
Well, and I will also add, though, that this is an area of focus for our parity committee. Sent out a provider survey. We have distributed that through all of our various provider associations, asking folks to give us input on what their experiences were as providers or as consumers or as family members in getting needed services approved. And the fact is that independent clinical practices do not have a room full of third-party biller folks to jump through all of these hoops. And a family who is dealing with a young adult with a severe addiction problem does not have the wherewithal in between going to work and also trying to take care of their family member to fight procedures and appeals and jump through these hoops as well. So even though sometimes these cases end up being misunderstandings or forms that weren't filled out properly or technical glitches, it does represent one of the barriers that mental health parity tries to solve, but does not always. So we as the Mental Health Coalition are very interested in collecting this information. And then we are running it up the chain to the applicable regulators to give them a window into what is happening on the ground. So I don't want any participant in this webinar to think that there are no options, that it's just going to get worse and worse. And I'd be very interested to know what the other panelists think. I think the national focus on mental health parity is going to grow as we move on from the pandemic and the growing crisis of mental health across the country. Any other thoughts?
I would certainly concur with that. And I think this, one of the processes that I think is a frustration for a lot of providers is what we're looking at prior authorizations and this, you get 3 appointments and then you have to be reviewed again. And it's a process that's happening not just in behavioral health, with a lot of other healthcare. And I know that we are seeing a lot of focus on addressing that and streamlining that, because while it probably does have a role in the process, it does not have to be as onerous as it is, because you're absolutely right. I think what Dr. Prohaska was sharing was it interferes with the provision of care. And if our goal as providers is to provide care, anything that does that it's got to be fixed. So I think we'll be seeing a lot of work on that, both at the federal and potentially at the state level as well.
We have another question here that I think is, Mary, did you have a comment?
Well, I was just, this is a little more opinion based, but I was just at a national seminar a little over a week ago, and the panelists were comprised of people who worked directly with the WIT versus UBH case. And I would say that I think this does need to be a priority area for the simple reason that, and certainly Sandra, not reflective of what you do at United Behavioral Health, but there are, pushes to, as many people move to private practice and move to non-insurer and cash pay only, really it in some ways does the system harm, because people need insurance, they need to access their insurance benefits, and in some ways, for lack of a better word, sort of the insurance company wins in that, because then people aren't using the benefits that they're entitled to. So again, certainly from a different perspective to look at the issue as a larger system issue, what happens when we encourage people to not take advantage of the benefits in which they're entitled to.
I think that's very true. There's a question here. It says, I've been trying unsuccessfully to understand parity from another angle, i.e., how is the start and stop time documented for a visit to my physician? Is the time they spend reviewing my chart before they enter the room included, which is not the case for mental health practitioners? Is the time they spend writing their notes after I leave included? Again, not the case in mental health. I think so. These conversations have been occurring for a number of years. And what happens is, if you notice some of the federal language relating to mental health parity, it speaks kind of specifically to financial restrictions, access to care restrictions, medical necessity determinations. And so when you get to this level, this granular level of claims, it's almost like the whole discussion sort of runs out by the time it gets there. But what I find interesting is, how does this relate as we move forward into a time where we're talking about a different form of payment, right? Plans are moving away from fundamental fee-for-service in 15-minute increments to more of quality care-based payment systems. And so all of these things sort of merge in together in those conversations, because if there was an overall payment system that was based on the treatment plan and wasn't about, did you spend 15 minutes face-to-face to the client today, that would sort of eliminate those considerations. Then it comes down to the negotiation of whether or not the payment is enough to support the service. Does anyone else have any thoughts? I think
I agree, Amy.
Yeah.
I agree. I think our system is not quite there yet. Having been a part of configuration for the Ccbhcs, and what a challenge that has been, moving from a fee for service to a prospective payment, we've got a little ways to go. I'll just say that. But I agree. I think moving towards a bundled payment or a measurement-based system, I think is where we eventually will end up. but we're not there yet.
And I think it's an important question, because if you bring this up in a policy making format, then the response is, well, that's all between the contract between the provider and the insurer, as if there is a great deal of flexibility in those contracts and what a provider can sign up to do. So I do think it is something that is very, it's a worthwhile conversation to occur, because really at the end of the day, it's not whether or not it's being billed in 15-minute increments and what those requirements are. It's that the overall reimbursement isn't sufficient for everything it takes to provide that service.
Well, and your infrastructure within your state system has to support it. And ours currently does not.
I'm seeing something else, and I'm sorry, please feel free to talk amongst yourselves as I try to scan the chat. Yeah, this is again about the question of folks deciding that it's really more important and maybe they'll end up just doing private pay. I think that is a very understandable. It's understandable that clinicians are considering moving entirely to private pay. What is one of the other negative aspects to that a lot of people don't talk about is that then the behavioral health care that individuals are receiving occurs completely outside of their formal medical record. And there's no way for their primary care provider or a hospital or anyone else to have any idea what the history is, what they have been receiving, what they've engaged in, or anything like that. So in the last few minutes that we have today, I want to say that it is our goal as a committee to host future webinars. We want them to be relatively informal. We want to invite folks to talk that you want to hear from. And we also want to hear many sides and concerns of an issue. We want to hear the priorities of private clinicians. We want to hear the problems that are being faced by hospitals or larger agencies. And then what we want to do as the Kansas Mental Health Coalition is we want to represent those voices to the best of our ability and to facilitate a greater understanding of what parity laws can accomplish and what kind of comes outside of that. The Kansas Mental Health Coalition does lobby at the State House. I basically am at the Kansas State House full-time during the legislative session. We have a great deal of success with policy change at the state level when we collaborate with other folks, other mental health stakeholders, and it's been very successful, and the state agencies that we work with, and we've been very successful over the years. Before we sign off, I would like to offer an opportunity to any of the panelists to make a closing comment.
Just want to say thank you, Amy, for the opportunity, and I look forward to continued conversation.
Thank you, Sandra. I think you've been very brave to be the first insurance representative to jump into our webinar, but you've been a good friend to the coalition over the years in working to find solutions, not just within our coalition, but also with the legislature and the Mental Health Modernization and Reform Committee. So with that, I will close webinar number 1. All of you who have participated today and registered through the website have become a quote unquote contact of the Kansas Mental Health Coalition. This means you will receive some emails from the Mental Health Coalition, and if you do not want to, please feel free to unsubscribe, but we will be sending out the future webinar notices on these topics.